Dr. Sapna.
Good afternoon, everyone. It's a great pleasure to introduce our second speaker, Dr. Vikneshwari Ayadurai. She is best known as Dr. Vicky, and currently she is the consultant family medicine specialist in charge of Clinic Kasihatan, Taman Medan, under PKD Petaling. Dr. Vicky obtained her postgraduate qualification as a family medicine specialist from University Malaya in 2002. Her main interests are in infectious diseases such as HIV and dengue. She is the technical advisor for the Communicable Diseases Unit and the HIV/AIDS unit of the Petaling District Health Office. And she's also the program coordinator for the harm reduction program in PKD Petaling. She has been involved in the management of cases of HIV from the AZT monotherapy era in the 1990s until now. She's been actively involved in conducting training of medical officers working in the Petaling Health District in the management of dengue, HIV, and TB. She also works with NGOs and other government agencies in programs related to HIV, drug abuse, and dengue. Today, she will be sharing with us the steps for voluntary testing and screening for HIV. Ladies and gentlemen, please join me in welcoming Dr. Vicky.
Hi, Dr. Vicky. Your mic is currently muted.
Okay, can you hear me now?
Yes, Doctor.
Okay, thanks. Thank you, Dr. Sapna, for that introduction. And I'd also like to thank the organizers for inviting me to take part in this webinar. I've been asked to talk about voluntary testing and screening of HIV. And I'll be going on to do that in the next few minutes. Prof. Adiba has given us a very broad overview of the situation in Southeast Asia. And yes, as she said, there's a lot of doom and gloom involved. But I believe some of the things that they are doing overseas are things that we can also do here. And I hope we'll be able to do that, be motivated to do that after this webinar. Can I have the next slide, please? Okay, I'll be talking about why testing is important and what the barriers to testing are. I'll be talking about where people can come forward to get tested and what tests we do and offer, and how to interpret the results of these tests. I can't stop at testing because after testing, we have to go on to treatment and to linkage to care. So that will be the last part of my talk. Next, please. Why do we need to get tested? It's because it's only when you get tested that you will know your status. And as far as possible, we would like people to be tested early so that we can detect the HIV illness early in the stage of the infection. So only then that people will be able to take the necessary steps, which are essential and critical for prevention of HIV transmission to other people, and also for care and treatment of the HIV-infected individual. If once we know our status, we can also have a reduction in transmission of HIV to the general population, as well as a reduction in morbidity and mortality to the HIV-infected individual. Next, please. Studies have shown that nearly 40% of new HIV infections are transmitted by people who don't know they have the virus. For people with undiagnosed HIV, testing is the first step for them to start maintaining a healthy life and preventing HIV transmission. Contrary to what people used to say, if I get HIV, if someone gets HIV, they may go out there and try to purposely infect lots of people because they are in a revenge mode. Actually, we find that most people who know that they have HIV will change their behaviors. Next slide, please. Most of them will substantially reduce the risky sexual behaviors that they have that might transmit HIV to others once they are aware of the infection. A meta-analysis of 8 studies showed that the prevalence of unprotected anal or vaginal intercourse with uninfected partners was 68% lower for HIV-infected persons who were aware of their status than it was for HIV patients who were unaware of their status. So just knowing that they are HIV positive makes them change their behavior and thus reduce the risk to others. Next, please. People with HIV who take their HIV medications as prescribed and who get and keep an undetectable viral load have effectively no risk of transmitting HIV to HIV-negative sex partners. In HIV, viral load is one of the buzzwords, as Prof. Adiba mentioned. It's the amount of HIV virus that's floating around in a person's body who has HIV. The lower the viral load, the better it is for the patient's health. And our aim in treatment is to achieve an undetectable viral load where the virus is still present in the body because, as you know, we have no cure for HIV yet, but it's at a very low level that doesn't cause any damage to the person. Next, please. Knowing one's HIV status can also achieve reduction in mortality and morbidity to the person with HIV. Once someone is aware of their diagnosis, they can be started on antiretroviral therapy or ART, and once they're on treatment and they take it properly, they can achieve an undetectable viral load where they keep the virus level very low in their bodies. This enables them to remain healthy for many years, to be just like anyone else in society as far as the HIV infection goes. The sooner people start treatment after the diagnosis, the more they will benefit from the ART. So that's why we want people to get tested early, start treatment early, and benefit the best from the treatment available. ART helps to reduce the HIV levels in blood. This leads to less HIV-related illnesses, what we call opportunistic infections, where rather peculiar illnesses that don't normally affect well people, affect people with low immune systems, as seen in HIV people who are not on treatment. So this will be reduced in people who are on treatment. And HIV and ART also helps to reduce transmission to non-HIV infected people. Next, please. In Malaysia, what Prof. Adiba was talking about generally in Southeast Asia mostly, so I will go a little bit more into Malaysia. In Malaysia, we have the National Strategic Plan for Ending AIDS in Malaysia 2016-2030, or the NSPEA. Next. The NSPEA has the goal also, like worldwide, of ending AIDS by 2030. We hope to do this by achieving the treatment targets of 95, 95, 95, which I'm going to repeat, although you've heard this before, because this is what we're trying to do, where 95% of the key population gets tested for HIV and knows their results. Of these who know their results, 95% of them, we hope, will receive antiretroviral therapy, and of those on therapy, 95% of them hopefully will achieve viral suppression. Again, in Malaysia, our HIV epidemic is what we call a concentrated HIV epidemic, where it's mainly among the at-risk population, female sex worker, the transgenders, people who have injecting drug abuse habits, and men who have sex with men. So if we can achieve accessing treatment and testing in this group of people, we will be able to reduce the number of cases of HIV. Under the NSPEA, we also have a prevention target whereby 90% of these key populations are also reached by combination preventive services, which means not only from the health ministry, but also from NGOs and other bodies who can help. Next, please. Next, yeah. For HIV management, we have a continuum of engagement. We start from the left of the diagram, where people who have HIV are unaware of their status. Either they have never been tested, or they have been tested but didn't come forward or come back to receive their results. Our aim is to try to make them aware of their status and get those who are not yet in care, or because they have not been referred to care, or they didn't go for their first visit after they were referred, to be linked to HIV care. Once they get linked to HIV care, we hope they will receive the initial HIV medical care that's available, whereby they will be counseled by the medical professionals, they will be started on antiretroviral therapy as soon as they are ready to start, and hopefully keep on it. So after linkage, they need to be retained in care, whereby they will receive follow-up medications and follow-up visits to the medical team for them to keep on being managed properly. We have many ways of doing this now. We have cases, we have tried many ways of making sure people get retained in care by making them, once they come forward and get tested, once they get treated and achieve viral suppression, we can lengthen their appointments so they don't have to come so often to the clinics. We provide things like telephone consultations for those who are stable, virtual consultations for those who are stable, so they can skip a couple of appointments to the clinic, but still remain in touch with their care professionals. And then we also have some places offer services on Saturdays or after hours so that those who are working can still come forward for treatment. Despite all this, we still see that people do have lapses in HIV care. Either they get lost to follow-up because it becomes too burdensome, or they just get fed up of seeing someone all the time, or they come for treatment, but they actually don't take their medications properly. these people have to be re-engaged into care so that they can resume HIV care and get back on track and get their viral load suppressed. Next, please. So the first 95 of the 395s in the priority programs of the NSPA deals with intensifying and expanding testing, including community testing. Next, please. The Ministry of Health offers voluntary and confidential testing, or VCT, which is client initiated. This is where someone who may feel that he or she has a risk factor for HIV, or being infected with HIV, comes forward himself or herself to the clinic or to whichever testing site and asks to be tested. The other option is where it's provider-initiated testing and counselling. This is where the healthcare provider who is seeing a patient has a reason to believe that this person may either have a risk of HIV, may have a risk of HIV infection, or have already been infected by HIV, maybe because of the history that they elicit from the patient, or because of the findings that they get when they examine the patient. Next, please. Barriers to people coming forward for testing are many, but again, as Prof. Adiba said, one of the major ones is the absence of perception of risk for HIV. Many of our patients, especially our young ones, just feel that they are not at risk, even though they know they are practicing risky lifestyles. I recently had a 21-year-old gentleman who came for treatment for a sexually transmitted infection. And after counseling him, we also tested him for HIV, which unfortunately turned out to be positive. He's been practicing risky behavior from the age of 17. And when we asked him about his risks, he knows that unprotected sex is a risk factor, but he still says that, well, my partners looked healthy, my partners looked handsome, my partners looked clean, so I didn't think I was at risk for HIV. And this is very sad because he's only 21 and now he has HIV. Others don't come for testing because they are fearful of the disease. They have seen maybe the older promotions that we used to do under the Ministry of Health, where there wasn't very much treatment for HIV. We used to use the scare tactics about HIV and how bad it was. Some people may still think about this and fear knowing about the disease, so they just rather not know about it. Others have fear of the social stigma if disclosed. Unfortunately, because HIV in Malaysia is mostly in the at-risk population, this group of people are unfortunately often stigmatized, and so they feel afraid that if they get tested and people find out, they will be ostracized from their families, their communities, and so they don't want to come forward for testing. Sometimes it's not even fear, it's just that they don't have access to HIV testing. No doubt HIV testing is widely available in Malaysia, but because, again, this key population may find it difficult to come forward to a government health center or even a private health center because there's a cost factor involved, and so they have poor access to this HIV testing. Many communities feel that when they do come forward for testing, they are entertained by inappropriate counseling from the healthcare providers whom they see, by the moralistic attitudes of healthcare providers towards their sexual practices. So they feel very uncomfortable when they come forward for testing. Some patients, some patients feel that, yes, even if I have HIV, I don't want to be on treatment because I don't want to be on treatment. I don't want to take medicines and be dependent on medicines lifelong. So that's another misconception about how bad it is to take medications. Next, please. And another barrier to testing, which is the COVID barrier, the new barrier we face in 2020, is because of our many movement control orders. Our first complete lockdown of movement control order from March onwards, and then our recovery movement control order, and now our conditional movement control order. We don't know what's going to come tonight to tell us what's going to happen for the rest of the year. All this have had the effect of reducing so-called unnecessary visits to the clinic. One, because people are scared to come to the clinic because they feel the clinic is a place where COVID is going to be roaming all over. And also because even we at the healthcare side were trying to reduce congestion in the clinics and controlling the number of people present in the clinic at one time, again to prevent unintentional spread of COVID. So our screening cases were very much less over the last few months. Fortunately, now we are starting to see an increase in numbers of patients coming forward for testing again, especially those brought in by the NGOs. The NGOs have been marvelous. They still go out to the community to still find people who are at risk and to encourage those in these key populations to come forward to our clinics. They bring them to our clinics for testing, and so we are seeing more people tested again. Next, please. So this is one of the common reasons for not testing is they don't want to know. It'll just be an ostrich, bury my head in the sand, and it will go away if I don't know about it. Unfortunately, next please, it doesn't go away. Whether you know you have HIV or you don't know you have HIV, if the virus is there, it's replicating, and it's multiplying. So whether you know or not, it's there sitting quietly in you if you have it, and I always tell my patients, the virus is getting married, they're just having more and more and more babies, and all these babies are going to cause problems to you if you don't do something to stop it. Next, please. So what tests do we have for HIV? HIV testing is done in 2 stages, the screening stage and then the confirmatory test. Next, please. The screening test that we do is an antibody test. It looks for antibodies that are produced by the body when HIV enters the body of a patient. HIV tests are very accurate, but no test can detect the virus immediately upon infection. How soon a test can detect HIV depends upon different factors, including the type of test being used. Please. Antibody tests can take 23 to 90 days to detect the HIV infection after exposures. This means that if someone gets HIV today, it may take up to anything between 23 to 90 days before the test that he takes can detect the HIV infection. This period is known as the window period and is a rather dangerous period because during this period when the patient actually has HIV, he may not know he has HIV, but he can still transmit the virus to others. This is why it's very important before or when we do the testing, we do some amount of counseling to the patients to elicit their risk factors, what those factors were, and when they engaged in those risk factors. If the risk factors was very recent, then we would encourage the client to come back to do a repeat test if the first test was negative or non-reactive, if he had those risk factors. Next, please. The test itself is very simple. It's just a finger prick requiring a drop of blood and takes about 20 minutes to get the result. Once the screening test is done, and if it's reactive, we need to proceed to a confirmatory test. For the confirmatory test, blood is taken and sent to the hospital lab for processing. The result will take time depending on the logistics, how far the clinic or the testing center is from the hospital and how fast the turnaround time to pick up the results and so, but generally it's in about two weeks. If the result comes back as positive, then the patient is told to be HIV positive. If the result is negative, we will elicit history again from the patient. Sometimes when we see them the second or third time, they're more open and they're more happy to tell us the real story. So we get a different history about their exposure. We will again advise them about the risks if they are practicing risky behavior and ask them to retest if necessary. Where can these tests be done? All government health clinics or clinic kesihatan provide these tests. Many clinics now are what we call STI-friendly clinics or sexually transmitted infection-friendly clinics. This is just something we have tried to do because, as I said before, people find it difficult to come forward to health clinics with the fear of stigma, the fear of the bureaucracy and such. So some clinics have worked together with NGOs from Malaysian AIDS Council, where the NGOs have come to the clinic. We've taken them around the clinic to introduce them to the clinic staff, from the registration to the paramedics who do the test to the doctors. So both sides get familiar with each other, and hopefully this reduces the barriers, the stigmas, the ostracization. Some GPs also provide testing. Most hospitals provide testing, and now we have NGOs in the community providing testing as well. This again is because of those from the at-risk population who have difficulty or fears about coming to the health facility. Outreach workers have been trained by the Ministry of Health now to perform these screening tests themselves. So they bring the kids down to the community, they go down to the at-risk population and offer the testing at the community centers itself, either at their homes or sometimes in the drug addict pods, wherever the at-risk population is present. Once these tests are done, if they're reactive, then the NGOs workers will try to link these clients to the health facility and try to bring them forward. So now they have this system whereby they sort of adopt the client at risk and they try to encourage them and accompany them to the clinic as well to help them get over the fear and the barriers at the first instance. Next, please. After testing, what happens? You can't stop just at testing. Next, please. Okay, then we go on to the second 95 of the 95. This is where we need to intensify and expedite introduction to treatment of all people living with HIV. Next, please. So to achieve the second 95, we need to be able to link people to care where they can be started on treatment. There's a long history of HIV treatment in Malaysia from the late 80s to now. So when do we start treatment? Previously, the timing of initiation of treatment was dependent on the level of CD4. CD4 cells are the white cells in our body's immune system, and these are the ones that are targeted by the HIV cells, by the HIV virus, sorry. The lower the CD4, the more advanced is the disease. So when we start treating people and HIV virus load goes down, the CD4 cells start going up again. So previously we used to start when CD4s were very low at 200 or less. Then we upped our game to 350. Then we went up to 500. And now we say test and treat. The sooner the better. Like how they do it in Thailand, they test this, they get the result and they start treatment on the same day. I think we haven't reached that level of excellence in Malaysia yet, but we are really moving fast to start treating the patient as soon as possible. Next, please. Current HIV treatment guidelines do recommend ART for all persons with HIV, regardless of the CD4 cell count, because we know it improves health, prolongs life, reduces risk of transmitting HIV to others. Next, please. What do we start the patient on? Previously, we used to just start single drug AZT monotherapy, which wasn't very good, but was all we had. We then moved on to 2-drug therapy, and now we have gone, generally, most people are on at least a triple combination of drugs. Previously, treatment regimes were very heavy. We used to have to take about 4 to 6 tablets 3 to 4 times a day. Now, all it takes generally is 1 to 2 tablets once a day. Previously, the regimes were really complicated. Some of that 4 to 6 tablets 3 to 4 times a day had to be taken before food, some after food. Some of those tablets had to be kept in the fridge, which made it very difficult for patients who have to go to work. Some tablets were huge and they needed to be crushed and drunk, and they tasted awful. So it was very difficult to get people to stay on this horrible treatment. Now it's really simple. It's just a simple regime, swallowing tablets once a day. Next, please. Where is treatment available? Previously, treatment was only available in the major government hospitals. When I was treating HIV in the 1990s, I think we had only 3 or 4 facilities in the whole of Malaysia. So we in HKL used to see people coming to us from Kuantan in the east, from Johor Bahru in the south, which entailed a travel time of 4 to 6 hours to get to us, and then to hang around in the clinic for your appointment, and then to travel all the way back, and then come again for your blood test. It was very difficult. Now it's really easy. All government health clinics with family medicine specialists in them offer HIV treatment. Most government hospitals offer treatment. Some private clinics do, and private hospitals as well. So there's a vast range of treatment options available, treatment placement available, which should be able to cater to everyone's needs. Next, please. And the best part is the cost. Previously, it used to cost more than 1,200 ringgit a month for treatment. And this was when 1,200 ringgit could get you a lot. So we used to run what I call a loan shark department in HKL, where my consultant, Chris Lee, would call the family members of the patient with his consent and then tell them that your brother or your son needs treatment and he can't work because he's really sick. How much can you come up with every month? And he would get the family members to commit to giving 200 a month or 100 a month or 500 a month until he got that 1,200 a month that the patient needed, until the patient was well. Now, treatment is free in government facilities for first-line treatment. So there's really no excuse not to take treatment. Next, please. So the third 95 in the priority programs of the NSPEA are to ensure adherence to peer support and quality case management. We know that people drop out of treatment because it's difficult, they feel the stigma, they feel like it's too much of a burden. So we really need to help them get through this next stage. Next, please. We have many ways now that we try to ensure adherence. In the Ministry of Health, our paramedics are going for post-basic training as counsellors, and they come back to the health clinics and hospitals where they work as counsellors to help us manage our HIV patients. Our clinic pharmacists do what we call medical therapy adherence counselling, where they talk to the patient in one-to-one about how they can best stay on treatment. We use tools like, because HIV treatment has been taken at the same time every day, we help them to figure out tools like using an alarm on their clock or their phone and how to remember to take the medication. And now with the NGOs coming on board, they help to buddy with patients with HIV to give them peer support and encouragement to carry on with treatment. Next, please. So the aim of treatment, finally, is to achieve an undetectable viral load, where the level is so low that it's not harmful to the person with HIV and hardly constitutes any risk of transmission to other people. the virus is there in the body. It's not cured. It still remains dormant in the body. So some people just find it very difficult to accept that I need to have to take treatment lifelong. So it's up to us to try to make them look at it positively and tell them all the positives about treatment. It's free, it's available here, it's just one tablet, it's so easy. And it's just like any other disease, any other chronic disease like diabetes, like hypertension. We have no cure for these either. And patients with diabetes have to take their anti-diabetic medications for the rest of their lives. They also have to control their food and do exercise, which an HIV positive person doesn't have to worry so much about. So you can still have your teh tarik and your roti canai while you take your HIV treatment. So that's what we try to tell them. And the benefits of taking treatment and being on treatment means you can live as any other person in Malaysia. Next, please. So we're trying to achieve U equals to U, where HIV undetectable in the body is untransmittable or untransmissible, whereby people with HIV who achieve and maintain an undetectable viral load by taking antiretroviral therapy daily as prescribed do not sexually transmit the virus to others. So not only is taking HIV treatment something to help the patient with HIV, him or herself, it is also treatment as prevention to prevent others from getting HIV. Next, please. So in conclusion, I'd like to remind everyone, if you have risk behavior, well, of course, initially we would like to encourage you to reduce your risky behavior, to be cognizant of the fact that what you're doing is risky and you need to reduce the risky behavior to be safe and healthy. We encourage anyone with risk behavior to get tested. And if you cannot stop the risky behavior, then you need to continue repeat testing, maybe every 3 to 6 months, so that if you do get HIV, we pick it up at an early stage and start you on treatment. Once you get tested for HIV and you are confirmed to have HIV, then we would like you to get started on treatment as soon as possible. Once you're on treatment, we encourage you to stay on treatment so that you can achieve an undetectable viral load and remain healthy. Thank you.